Surgeon was mid-operation. The robotic navigation system went dark. The patient database gone. The instrument tracking software offline. The surgical team looked at each other across the operating table. The tools in their hands were still there. The patient in front of them was still there. But everything that connected those two things to the hospital's digital infrastructure had simply stopped. This is not a hypothetical scenario designed to frighten you. This happened in early 2025. Cyberattack hit Stryker Corporation, one of the world's largest medical technology companies. Stryker makes the robotic systems surgeons use to replace hips and knees. It makes the navigation platforms that guide instruments during spinal surgery. It makes the software that manages surgical inventory, the integration systems that run operating rooms, and the implants currently sitting inside the bodies of patients in dozens of countries. The attack wiped more than 200 systems. It destroyed an estimated 50 terabytes of data. It disrupted the company's global network across 79 countries. The Wall Street Journal confirmed it. ABC News confirmed the network interruption. Stryker confirmed the incident itself. The data that was erased was not financial. It was medical, device specifications, surgical protocols, patient-linked implant records, information that hospitals depend on to operate people safely. That is the part that should stop you cold. Not a bank, not a government agency. A company whose products are inside people's bodies right now. And its global network went offline. This is where the story of healthcare cybersecurity usually stops. A news cycle, a press release, some reassurance about system restoration, and then the world moves on, but the pattern does not stop. And if you depend on the healthcare system or on any medical device or medication to stay alive, the pattern matters more than the press release, because Stryker was not the beginning. In May 2017, the WannaCry ransomware attack spread across the globe and hit the United Kingdom's National Health Service with particular force. 80 NHS trusts were affected. Hospitals across England and Scotland cancelled appointments. Ambulances were diverted. Operating theaters were closed. Patients who needed urgent care were turned away from emergency departments. Staff reverted to pen and paper. Phone lines went down. CT scanners, MRI machines, and blood test analyzers that depended on network systems either shut down or became inaccessible. The NHS had been warned years earlier about its outdated systems. The warning was not acted on, and over the course of a few days in May, patients paid the price in canceled surgeries, delayed diagnoses, and disrupted care. 3 years later, in September 2020, Universal Health Services, one of the largest hospital networks in the United States, suffered a ransomware attack that took down systems across approximately 400 facilities. Nurses and doctors worked through the night with paper charts and handwritten medication orders. Laboratory results that normally appeared on screens within minutes took hours or could not be retrieved at all. Pharmacies could not verify medication histories. Patient who needed a specific drug combination and had no paper record of their allergies was a problem no backup system had prepared for. The disruption lasted weeks. In 2023, Essentia Health, a regional network in the upper Midwest, experienced a cyberattack that forced staff to disconnect networked medical devices. Infusion pumps that deliver precise doses of medication were taken offline and switched to manual operation. Automated medication dispensing cabinets, the systems hospitals use to track and dispense drugs, became unavailable. Staff worked without the digital safety checks that normally catch dosing errors and drug interactions. The pattern is not that cyberattacks happen to hospitals. The pattern is that when they do, the things that stop working are not administrative. They are clinical. They are the systems that deliver medication, track allergies, guide surgery, monitor vital signs, and communicate between departments. The things that keep patients alive. Now here is the question nobody is asking. What happens to you, specifically, if those systems were unavailable for 7 days? Not to a hospital abstractly, to you, to your medication, to your medical devices, to the things you depend on every day without thinking about it. Let's walk through what actually stops working inside a hospital when digital infrastructure goes down for an extended period. Electronic health records are the first casualty. Your allergies, your medication history, your previous diagnoses, your surgical history, the results of every test you have had for the last decade. All of that lives on servers when those servers go offline. A nurse treating you in an emergency does not have access to any of it. They work with what you can tell them, what your family can tell them, and what is visible on examination. In a minor situation, that is inconvenient in a critical one. An unconscious patient with a severe drug allergy, an unusual reaction to anesthesia, a complex cardiac history. The gap between what the medical team knows and what they need to know can be the difference between the right decision and a fatal one. Laboratory results are the second casualty. Modern hospitals process thousands of blood tests, urine tests, and cultures every day. The results flow digitally from the lab to the clinical team in near real time. Without that flow, clinicians cannot get timely results for blood glucose in a diabetic patient, cannot verify kidney function before administering a drug that the kidneys must clear, cannot track the response to a blood pressure medication. Decisions that normally take minutes take hours, or they are made without the information that would change them. Medication dispensing is the third. Hospitals use automated dispensing cabinets, essentially locked, computerized medication lockers that track every dose removed and cross-reference it against the patient's chart for allergies and interaction. When those systems go down, the safeguards go with them. Nurses manually record every administration. The checks that happen automatically in working software must now happen in someone's memory. At the end of a 12-hour shift, in a building where half the systems are not functioning, surgical navigation and robotic systems are the fourth. Modern orthopedic and neurosurgical procedures increasingly rely on digital navigation. Systems that tell a surgeon, in real time, precisely where an instrument is relative to the patient's anatomy, cross-referenced against preoperative imaging. These systems are connected. When connectivity disappears, elective surgeries are canceled. The more complex the procedure, the more it depends on systems that are no longer available. Patient monitoring in intensive care units is the fifth. ICU patients are connected to monitors that track heart rate, oxygen saturation, blood pressure, respiratory rate, and dozens of other parameters continuously. Those monitors send data to central nursing stations, and in many systems, to automated alert platforms that flag dangerous changes. When the digital infrastructure is disrupted, monitoring becomes more manual, response becomes slower, and the margin for undetected deterioration widens. That is, the hospital now step outside of it. There are tens of millions of people in the United States alone who depend on medical technology outside of a hospital setting, not for convenience, for survival. If you use an insulin pump, you already understand that your life is maintained by a small computerized device that communicates with sensors and smartphones. Most modern insulin delivery systems depend on Bluetooth connectivity to continuous glucose monitors, and many connect to cloud platforms that track dosing and alert caregivers to dangerous fluctuations. A power outage that lasts 7 days is not just an inconvenience. It is a disruption to the chain of information and power that keeps blood sugar within survivable range. If you use a home oxygen concentrator, you depend on electricity to breathe adequately. These machines are not battery-backed. They require continuous power. A 7-day outage, someone with severe COPD or chronic respiratory failure, is not a scenario for discomfort. It is a medical emergency from day one. If you use a CPAP machine for severe obstructive sleep apnea, you likely have some battery options. But most people do not have them charged and tested and ready. 7 nights of untreated severe sleep apnea put significant stress on the cardiovascular system. For people with existing heart disease or poorly controlled hypertension, that is not a theoretical risk. If you take refrigerated medication, insulin, certain biologics for autoimmune conditions, some vaccines, certain injectable medications, you have a window. Standard refrigerated insulin, once kept at room temperature, remains usable for approximately 28 days. But that clock starts the moment power fails, and most people do not know exactly when their current supply was opened or how long it has been running at room temperature. A 7-day power outage does not automatically ruin your insulin, but it means you need to know your supplies, your timelines, and your backup plan. And most people have none of those things written down. If you are on dialysis, either at a center or at home, a 7-day disruption to medical infrastructure is not survivable without a plan. Dialysis is not a treatment that can be paused and resumed. It is continuous waste removal for kidneys that have permanently lost that function. Missing a dialysis session has measurable metabolic consequences within hours. The population that depends on medical technology to survive, not just to feel well, is larger than most people conceptualize. Because most people, when they are not in that population, do not think about it at all. Now let's talk about what you can actually do, not about geopolitics, not about which government is responsible for which attack, about the practical, achievable steps that convert a dangerous vulnerability into a manageable one. The first layer is medication. Most prescriptions in the United States are written for 30 days at a time. Most insurance plans allow refills only when a certain percentage of the previous supply has been used. This means that at any given time, most people are operating with a week or two of buffer. Not 30 days, not 90 days. If your pharmacy goes offline, your insurance portal goes offline, or your medication requires a prior authorization that cannot be processed. That buffer disappears quickly. Talk to your prescribing doctor about a 90-day supply. Many insurers allow this for maintenance medications. Drugs taken indefinitely for chronic conditions like hypertension, diabetes, thyroid disease, or mental health. A 90-day supply kept properly stored gives you a meaningful buffer if the system is disrupted. If your medication requires refrigeration, understand its room temperature stability window, write it down. Put it somewhere you can find it without a working phone. The second layer is records. You have a legal right to your medical records. You can request a printed copy of your medication list, your allergy list, your most recent laboratory results, your diagnoses, and any implanted device information. A single printed document with this information, kept in a folder that does not require electricity to access, transforms you from a patient who depends entirely on a working digital system into a patient who can be treated safely even when those systems fail. This is not a dramatic step. It is a piece of paper, but it is a piece of paper that, in a hospital running on emergency protocols without functioning electronic records, tells the medical team who you are and what you need. The third layer is devices. If you use a device that requires power, a CPAP machine, an oxygen concentrator, a home dialysis machine, an infusion pump, a powered wheelchair, find out what backup power options exist. Some devices have battery packs. Some can be powered by a car adapter. Some have portable equivalents that are less comfortable but functional. Your equipment supplier or device manufacturer can tell you exactly what options exist for your specific model. Having that conversation before an emergency is the only time it is useful. After the emergency starts, the phone lines at your equipment supplier are already overwhelmed. The fourth layer is nutrition and hydration for chronic conditions. If you have diabetes, a disruption to your normal food supply, processed foods that have unpredictable glycemic effects, missing meals because of stress and logistical disruption, or conversely, eating whatever is available, can cause blood sugar swings that are hard to manage even with full access to medication. Keeping a supply of foods with predictable glycemic impact, knowing how your medications interact with changes in food intake, and having a simple plan for monitoring blood sugar manually if your connected devices are down. These are not exotic preparations. They are extensions of the management routine you already have. If you have kidney disease, sodium and potassium intake during a disruption can quickly move outside safe limits if the careful dietary patterns you maintain in normal life are disrupted by what is available or accessible. If you have heart failure or hypertension, sodium and fluid balance matter day by day. A week of disrupted diet and elevated stress is a week where blood pressure and fluid retention can shift in directions that, in normal circumstances, would prompt a call to your doctor. Having a plan for that call. Backup number, a telehealth option, a way to reach your physician that does not depend on a working app, matters. The fifth layer is emergency contacts and communication. Write down the phone numbers of your primary care physician, your cardiologist or specialist, your pharmacy, your nearest hospital, and at least 2 family members or friends who could help you navigate a medical crisis. Write them on paper. Your phone may be dead. The app you use to store contacts may not load. The cloud backup that contains your data may not be reachable. In a system disruption, the people who manage to get appropriate care quickly are disproportionately the ones who knew their own situation clearly and could communicate it clearly to whoever was helping them. Without a working smartphone, this is the gap that most people have not closed. It is not a gap that requires money or medical training or unusual access. It requires 30 minutes, a pen, a sheet of paper, and one conversation with your doctor. You cannot control whether a hospital's systems go down. You cannot control whether a cyberattack disrupts the network your insulin pump connects to, or takes down the pharmacy software your prescriptions run through, or wipes the records that tell a surgeon what is inside your body. What you can control is whether, when any of that happens, you are the person who already has the information written down, the backup medication in the cabinet, the battery charged and tested, and the plan that does not depend on everything working normally. The healthcare system is more vulnerable than most people realize. It has demonstrated that vulnerability, repeatedly, in documented events that made headlines and then faded from memory. The question is not whether you believe the risk is real. The question is whether you have spent 30 minutes acting as if it is. This video is for educational purposes only. It is not medical advice and does not replace a consultation with your doctor. The preparation steps described in this video, particularly those involving medication supply, device backup plans, and management of chronic conditions during disruption, should be discussed with your prescribing physician, your specialist, and your medical equipment provider before you need them. Do not change your medication, device settings, or treatment plan without professional guidance.